Now this patient was a routine phaco. You'll see that I've reached almost the end. I have this small fragment left, and just when that surge took place, if you notice, there was that small surge over there. I'll just show you that last piece that I was going to aspirate. Just notice here, I had this last piece and sudden surge, and I realized that something had happened during this step. And as I zoomed in, I noticed that, can you see this? I call it as the perfect PC rent. It has perfectly round edges. And just to replay this for you, and that small surge in slow motion, and then I just zoomed in and I noticed that, so it can happen so easily. It was just at the end of surgery. My tip is nowhere close to the PC actually. I'm just above the plane, and then I noticed this rent right here for that last piece. So tip is to put in viscoelastic from the side port, not let it enlarge. And then if you notice that there is vitreous presentation, you can go in and clear it up with a vitrector. Here there was no vitreous presentation, it was just a break in the PC. You can see that the IOL tumbled as well. So makes life more difficult. Sometimes when things are going wrong, everything starts going wrong. I managed to put this lens into the bag and save the day here. So this lens was fixed. Let me quickly come to one second video which I wanted to share with you. I won't show you the IOL scaffold and all because they've already been covered. Now here's a posterior polar cataract where I follow the usual precautions and make a slightly 5 to 5.5 millimeter rexus because for the hydrodelineation to take place. You can see that I do this hydrodelineation and get a golden ring, no hydrodissection here, but something probably didn't work well, maybe some fluid creeped into that plane as well. And I managed to, I don't rotate these nuclei much, and I try to remove these fragments one by one without rotation, as you can see here. Managed to get the nucleus out, and as Dr. Maipal was mentioning, sometimes at the end you are overconfident, you've got the nucleus out and you've just got this thing left. I should have been careful not to do a vigorous, this is all in fast forward mode, so you'll probably feel that it's going really fast. It wasn't as fast as this. This is where I made the mistake. This thing was adherent, the posterior polar plaque was adherent to the PC. I should have been cautious and releasing it using viscoelastic, but I managed to get a break here just trying to pull away those plaques. So you have to be very careful. Sometimes you finish the surgery and you feel confident that everything's gone off well, and you want that last bit to be, coming out fast enough, and you'll end up in this situation. Now you need to manage the vitreous here. You have to be careful, inject triamcinolone, and as in the previous videos we saw good efficient use of triamcinolone. It really saves the day. It's so easily available now. Every surgeon should have it in his armamentarium, and clear up the vitreous, and you'll be able to save the day. So here we were able to subsequently, after clearing the vitreous, get the cortex out, and you have to be a little patient here not to disturb the vitreous again. So once all the cortex is out, you can see that big break induced by me, and then I'm able to put in the lens here. Again, it probably goes into the bag in spite of that break, and I was able to finish the surgery efficiently. So you can actually put these lenses in the bag. I would not suggest multi-piece lenses, but single-piece lenses. And with that, I think I'll finish. We've exceeded the time, I think. Thank you.